This morning, we're highlighting researchers whose work Beyond Celiac has funded. And any remaining time at the end of their half-hour presentations can be used for questions, and then all of our speakers will join us for a whole panel of Q&A after the morning break. So I'll welcome our first speaker this morning, Dr. Stahl. Dr. Stahl received the 2019 Beyond Celiac Society for the Study of Celiac Disease Early Career Award. She is an assistant professor of pediatrics at the University of Colorado and works with the Colorado Celiac Disease Center. She is joining us today to talk about the Autoimmunity Screening for Kids study, a free health screening program open to all Colorado children designed to detect celiac disease and type 1 diabetes. Welcome, Dr. Stahl.
Thank you so much to the organizers of this event for inviting me to talk today. I'm very, very excited to share our preliminary results on the mass screening outcomes for pediatric celiac disease. This work was supported by the SSCD Beyond Celiac Early Career Research Award. I want to start out by talking a little bit about why even consider mass screening for celiac disease. Celiac disease meets a lot of the criteria for a disease that should be considered for mass screening. We know the disease is common. We have good screening tests. There have been many studies that show that diagnosis and screening is acceptable across different cultures. Thank you. We know treatment is available. There's the gluten-free diet. Clinical detection based on symptoms is incredibly difficult. Where celiac disease really falls short with respect to this criteria is we do not know if celiac disease is undiagnosed and untreated, that there is severe complications that hasn't been confirmed, and therefore the benefit of screening and identifying asymptomatic children with celiac disease is controversial. So we know celiac disease is common. These are the results from a recent meta-analysis in 2018 that showed that the pooled worldwide seroprevalence of celiac disease is 1.4%. But I would argue that despite significant scientific advances, this still really only represents the tip of the iceberg of people with celiac disease, and that this 1.4% is likely an underestimation. And in fact, in other screening studies, we have seen higher estimates of celiac disease. This is the data from an HLA frequency-weighted model from TEDdy. The top panel is celiac disease autoimmunity, and the bottom panel is celiac disease. And what you can see on this slide is that the black line represented by Sweden has an incredible estimated incidence of celiac disease of 3%. And Colorado doesn't trail too far behind. It's the green dashed line there, and it has an estimated incidence of 2.4%. I think most know that we have screening tests that are simple, safe, and accurate. This slide lists some of those screening tests with variable sensitivities and specificities. At the end of the day, the TTG IgA and total IgA level are really the preferred first-line screening tests for celiac disease. Treatment is available. Unfortunately, the only option that we have right now is a strict gluten-free diet. And at least in children, we think that they have pretty good mucosal healing on a gluten-free diet, although new data is coming out that this might not be as complete as previously thought. And new drugs in the pipeline will definitely change how we think about diagnosis, prevention, screening, and treatment strategies. Clinical detection can be incredibly difficult. This pyramid is based off of a review that looked at the prevalence of celiac disease when different criteria were applied as to who should be screened. And what you can see at the top of this pyramid is that when you screen based solely on malabsorptive symptoms, the prevalence of celiac disease is actually less than 0.1%. When you get to the bottom of this pyramid and you apply mass screening, that prevalence increases over tenfold. And part of the reason that clinical detection can be incredibly difficult is that as celiac disease is becoming more common, we recognize that there's a really wide spectrum of disease. The GI symptoms may be easier for providers to pick up on and therefore screen, but less than 1/3 of people will have these symptoms when they see a provider. The extraintestinal manifestations are much, much more common, and to complicate things even further, many people may have no symptoms at all. Despite all of this, due to the lack of evidence for the benefit of screening asymptomatic individuals, the USPSTF stated that there is insufficient evidence to support general population screening for celiac disease. And this statement was one of the motivations for the Autoimmunity Screening for Kids, or ASK study. This is a study that screens children ages 1 to 17 years old for islet autoantibodies and tissue transglutaminase. At an initial baseline visit, we collect baseline demographics, family history, we give them a basic symptom questionnaire, and we get that initial TGA level. For children that screen positive at that initial visit, they're invited back 4 to 6 weeks later for a confirmation screen. If they screen positive again, then they are referred to GI. And here are the results from the first 10,000 screened. What we found from the first 10,000 screened was that 2.4% of children in Colorado screened had undiagnosed celiac disease autoimmunity. Of those that screened positive, only 10% had a family history, and only 30% had GI symptoms. So our conclusions from this were that there is a high prevalence of undiagnosed celiac disease autoimmunity in Colorado, and most of the children identified in ASK would not have been caught by our current screening practices. And here are the outcomes of the first 10,000 children screened. Of the 108 who confirmed positive and were referred to GI, 62 were actually seen by GI, and 39 went on to be diagnosed with celiac disease. This brings me to our follow-up study of mass screening identified celiac disease. The overarching goal of this study was really to see what is the morbidity associated with screening identified celiac disease, and subsequently, does that morbidity improve with treatment with a gluten-free diet? And what I mean by morbidity is in AIM-1, we are looking at growth parameters, symptoms, and baseline labs. And then in AIM-2, we are looking at health-related quality of life. So this schematic is similar to the schematic that I showed you on the previous slide, but it's outlining the follow-up of the children diagnosed with celiac disease at our center. So for those kids that screen TGA positive in ASK, they're referred to our center for further workup. And for this specific study, we enrolled those with biopsy-proven, meaning MARSH2 or greater, or SBGAN-based celiac disease. At our baseline visit, we collected several questionnaires. We did our labs per our standard clinical care, and then baseline demographics, family history, medical history. And we collected similar information at our follow-up visit, which was 12 months later, but in addition also collected some gluten-free diet data. And this slide just highlights a little bit more on the specific symptom questionnaires. So the initial column represents the symptom questionnaire that's administered at that initial ask screen. This symptom questionnaire is administered before families know whether or not their child is TGA positive. And this questionnaire really focuses only on the gastrointestinal symptoms of celiac disease. The follow-up questionnaire is the questionnaire that we administered at all of our visits, so the baseline visit that I will show you in future slides and our follow-up visit. And this includes the extraintestinal manifestations of celiac disease as well. So once again, the data collected both at that baseline visit and then the follow-up or 12-month visit. We collected height, weight, BMI Z-score. We collected TTG IgA, ferritin, vitamin D, CBC, CMP, TSH, and this is all per our standard clinical care. And then we gave families the following questionnaires: the PEDS-QL Family Impact Module, which is a caregiver report, the PEDS-QL Core Scales, which has both a caregiver and a child report. The important thing to note about these two questionnaires is that higher scores denote better functioning. And then we gave the RCADS as a screen for anxiety and depression, and that is a caregiver and child report. And for this questionnaire, higher scores correlate with higher rates of anxiety and depression. So we used descriptive analyses for the baseline features of this cohort, and then we used pair-T tests and Wilcoxon sign rank tests as appropriate to compare that change from baseline to the follow-up visit. And here were our results. So we had 42 children who were diagnosed with celiac disease who have completed follow-up to this time. What you can see in this flow chart, which is organized by different age arms that we administer the PEDS-QL based off of, you can see that there was a pretty equitable number in each age arm, with the exception of the 2 to 4-year-olds. And we had pretty good complete follow-up sets for all of these 42 participants. And here are the demographics for the 42 children who completed follow-up. The other thing that we included in this table was a comparison of those who were asymptomatic at the initial screen, meaning they had no symptoms at that initial ask visit, and then those who had one or more symptoms at that ask visit, or the symptomatic group. And the take-homes from this table is that there was really no statistical difference in baseline demographics, labs, health-related quality of life, anxiety, or depression based on whether symptoms were present at the time of the initial screen. But one thing that was very interesting was that 27 of the 29 children who were asymptomatic at their initial screen had symptoms on our extended questionnaire at that baseline visit. And this table just compares the 42 children who completed follow-up to the 10 children who were enrolled and did not complete follow-up. I think some interesting points are that when you look at those who did not complete follow-up, they were more likely to be older, more likely to be male gender, more likely to be non-white race, more likely to come from a lower income household, more likely to be insured by Medicaid. There was no difference in most baseline labs, symptoms, health-related quality of life, or anxiety or depression in these groups. And when we looked at the baseline labs, iron deficiency was actually very, very common among this group. It was almost 80% of children who had iron deficiency at their baseline visit. The other baseline labs in general were not abnormal. And at the follow-up visit, what we noted for these 42 children was that even though most of them still had a positive TGA, most families reported excellent to good adherence to the gluten-free diet. So 52% of the children still had a positive TGA at their follow-up visit. This is actually not that surprising. All of the TGA levels were declining, and a lot of them started out with very, very high levels, and this visit was just a year after their diagnosis. 28 families had an adherence assessment with our dietitian. 16 reported excellent adherence, 10 reported good adherence, 1 reported fair adherence, and 1 reported poor adherence. So overall, in this group of screening identified individuals with celiac disease, gluten-free diet adherence was actually very good. And this slide here shows the spaghetti plots that track the hemoglobin, AST, and ferritin of these children from their baseline visit to their 12-month follow-up. What you can see all the way to the right is that the ferritin did show significant improvement from baseline to follow-up, and you'll remember that this was the only lab that in general was abnormal at baseline, so this really did show the most marked improvement in terms of normalization. The hemoglobin, interestingly, trended up, and the AST trended down, but these labs were not abnormal at baseline, so the clinical application of that is pretty limited. So on the next couple of slides, I'm going to focus on that initially asymptomatic group that reported symptoms at their baseline visit, so those 27 children. And I'm going to show you the progression of some of these symptoms. So abdominal pain was the most common reported symptom. There were actually 18 children that reported abdominal pain, and 10 got better after going on the gluten-free diet. So 56% of these children did improve. Diarrhea was an interesting one because this was also asked about at the initial screen. However, there were 8 children who did not report diarrhea at their initial screen who reported it at our baseline visit, and 63% of those children got better after going gluten-free. 7 children reported constipation at their baseline visit, and 5 still had constipation at their follow-up visit. So this was one symptom that did not seem to improve with the gluten-free diet. Interestingly, 8 children reported brain fog, and many of them actually got better after going on a gluten-free diet. It was 75% of these children that improved after going gluten-free. Similarly, headaches were very common, and 69% of children did improve after going on a gluten-free diet. Joint pain wasn't quite as common, but what you'll see with this symptom is that all 6 of the children who reported joint pain got better on a gluten-free diet. So this was one symptom that showed the most marked improvement after going gluten-free. It was 86% of children that improved on a gluten-free diet. This table greatly simplifies the progression of symptoms, and the evolution is much, much more complex. What this table doesn't show are the children who reported new symptoms at their follow-up visit. We also looked at healthcare-related quality of life in the asymptomatic group of children. And very interestingly, the caregiver reports of quality of life showed significant improvement in the physical, school, and overall functioning. And the child reports, while they trended improvement in all of these domains, it was actually not statistically significant. We also looked at health-related quality of life in the different age groups. And for children 12 years and younger, what we found and what you can see on the spaghetti plot to the left here is that for some individuals and some families, the family impact score actually trended worse with the gluten-free diet. And I think this just reflects the stress that the gluten-free diet can have on a family and really the importance of behavioral health support for all the families that we see in clinic. When we looked at quality of life, the caregivers actually reported significant improvement in physical, school, emotional, and overall functioning. The children also reported improvement, but it was only statistically significant in that school functioning domain. For children over 13 years old, we actually saw that the family impact scores trended improvement, although this was not statistically significant. And interestingly, for quality of life, the caregiver report trended improvement, but the child report seemed to be the same at the baseline and the follow-up visit. And then for anxiety and depression, or the RCADs, you'll remember that higher scores correlate with mental health concerns. And what you see on the spaghetti plots on this slide, both in the 13 years and older group and the 8 to 12-year-old group, is that overall anxiety and depression was not worse after starting a gluten-free diet. But once again, like the symptoms, this is incredibly complex, and there were individuals who had anxiety and depression at baseline that got better after going gluten-free, but there were also some individuals that developed anxiety and depression on the gluten-free diet. And finally, we asked all of our families about their attitudes towards celiac screening at that baseline visit. What we found was that 95% of families liked that they were able to have their children screened for celiac antibodies and thought that it was important that children were screened for celiac disease. We heard several themes when we asked why families participated in screening. Several thought it was great to know and were very excited about the idea of prevention. Several felt that it was important to support research that may help others with a potentially serious disease. Several thought that it was good to know if you have an autoimmune disease so that you can do something about it before you have serious health issues. Several families commented on the convenience of screening and that it didn't require an actual blood draw. Some said it was a just-in-case kind of thing, and then some did it because they had a family history. So in conclusion, I think this data shows that it's important for us to offer support and resources for racial ethnic minorities and lower income groups, as these were the groups that were more often lost to follow-up. There were many initially asymptomatic children who actually had symptoms on that extended screening questionnaire. And with that, the evolution of symptoms is incredibly complex. Most of these symptoms got better with a gluten-free diet, but some did not. Iron deficiency is very common and seems to improve with a gluten-free diet. Most of the families with screening identified celiac disease report good to excellent adherence at their follow-up assessment. Screening and treatment does not seem to be associated with increased anxiety and depression. Quality of life overall seems to improve with treatment, but this might be age dependent. And overall, I would say that screening seems to be beneficial, but in general, I think we need more personalized approaches to celiac disease, and I would also stress the importance of behavioral health support in the management in order to reap the most benefit from screening. So what do we plan to do next? We want to use the PEDS quality of life data that we have to evaluate the cost effectiveness of screening. I also think it's going to be really important for us to compare the outcomes of those identified by mass screening to those identified by targeted screening. And what I mean by targeted screening is screening of asymptomatic individuals in high-risk groups, which is already recommended by several national organizations. And then finally, we want to look to see whether initial symptoms correlate with anxiety, depression, and quality of life. And I just want to take a moment to acknowledge everyone without whom this research would not be possible. The Colorado Center for Celiac Disease, and particularly my research mentor, Dr. Ed Liu, the ASK team and the Barbara Davis Center, of course, Beyond Celiac and the SSCD, and our research participants, most importantly. We have HLA for some of the participants, but not all of the participants. Some of our other screening studies are HLA-based. This one was not.
How much, if you were to extrapolate this to a mass screening program, how much do you see that this would cost per screen if you were able to move that kind of effort forward?
So that's an excellent question. I don't have the answer for you now, but that is something that we are very, very interested in looking at. And actually, one of the things that I'm very excited about with this data is that we have 2 additional pediatric GI trainees who will be taking on some of these projects, and one who is particularly interested in cost effectiveness. So hopefully the next summit I'll have a better answer for you.